Welcome to tests of secondary hemostasis. In this video, we will discuss the prothrombin time, or PT. We have the following take-home points. The PT assesses the extrinsic and common pathways of coagulation. An isolated prolonged PT indicates an acquired or congenital deficiency in factor VII. The INR is a dimensionless ratio of patient to control PT. We'll begin with a review of the extrinsic pathway of coagulation. The extrinsic pathway begins when endothelial injury exposes tissue factor to the circulation. Tissue factor activates factor VII to factor VIIa. The resulting tissue factor VIIa complex acts on factor X and converts it to activated factor X. Activated X has as its cofactor activated factor V. This cofactor helps factor Xa convert prothrombin, factor II, to thrombin. Thrombin cleaves the zymogen fibrinogen and converts it to fibrin. Fibrin monomers combine to create fibrin strands, which are ultimately cross-linked by factor XIII to produce a strong fibrin clot. This first part of the coagulation cascade is historically known as the extrinsic pathway. Therefore, a deficiency or inhibitor of factor VII will result in an isolated prolonged PT. The common pathway is made up of factors X, V, prothrombin, and fibrinogen. A deficiency or inhibitor of one or more of these factors will prolong both the PT and APTT. The prothrombin time measures the time to a fibrin clot after plasma is exposed to tissue factor. It is measured in seconds. The prothrombin time is used to evaluate unexplained bleeding, diagnose disseminated intravascular coagulation, monitor warfarin therapy, and assess liver synthetic function. Causes of a prolonged PT include vitamin K deficiency, as induced by vitamin K antagonists, impaired nutrition, broad-spectrum antibiotics, or fat malabsorption syndromes. The PT is also prolonged by anticoagulants that inhibit common pathway factors, including warfarin, dabigatran, and bivalirudin. Because most PT reagents contain heparin binders, the PT is not typically prolonged by unfractionated or low molecular weight heparin or fondaparinux. The PT is also prolonged in liver disease due to decreased production of clotting factors. In disseminated intravascular coagulation, as coagulation factors are consumed and depleted. The PT can also be prolonged when there is a deficiency of an extrinsic or common pathway factor, in the presence of antiphospholipid antibodies or a lupus anticoagulant. The PT can be falsely prolonged with polycythemia when the hematocrit is greater than 55% due to excess citrate relative to plasma in the collection tube. Let's briefly discuss the International Normalized Ratio, or INR. The INR is the ratio of the patient's PT to a control PT obtained using an international reference thromboplastin reagent. Thus, the INR is dimensionless. Unlike the PT, which varies from lab to lab, the INR will be similar on a blood sample tested in any lab when calibrated correctly, allowing comparison at different times and/or locations, a great benefit for warfarin monitoring. The INR is used to monitor warfarin therapy, as a surrogate for the prothrombin time, and to assess end-stage liver disease as part of the Model for End-Stage Liver Disease, or MELD score. In summary, the PT assesses the extrinsic and common pathways of coagulation. An isolated prolonged PT may indicate a deficiency or inhibitor of factor VII. The INR is a dimensionless ratio of patient to control PT. This ends our video on tests of secondary hemostasis, the prothrombin time.